Welcome back to the deep dive. Today, well, we're rolling up our sleeves. We're diving into the real nuts and bolts of healthcare quality assurance. Specifically, the mandatory self-assessment procedures health establishments have to follow. Our guide for this is pretty official. Excerpts from the Health Standards Compliance Self-Assessment Procedures. So, this is straight from the source, our mission. To quickly map this out, not just read the rules, but understand how hospitals actually use these for quality control and reporting. Okay, let's unpack this.
Absolutely. And this is really about, let's say, self-governance in practice. We hear a lot about the big external audits, sure, but this internal self-assessment, this is where the continuous work, the real grind happens. It's meant to be a cycle of finding issues and fixing them before they impact care. The whole framework comes from the regulations governing the Office of Health Standards Compliance, the OHSC. They're the watchdog. And they're linked to the Health Ombudsman, who handles complaints from the public. Well, it means this internal process ultimately has public accountability baked right in.
Right, and the rules themselves are quite specific. The source points to two key legal bits. First, Section 4.2J. This says establishments have to submit results from their most recent annual self-assessment. That's the minimum expectation year on year. But then it gets more serious when certification renewal comes up. Section 19.2 demands more. For renewal, they need those annual self-assessments plus their latest quality improvement plans. They have to bundle them together.
And that link is critical. The regulations are basically saying, look, assessing yourself is one thing, but what did you do about it? The whole point of the self-assessment is finding those gaps, the deficiencies, and then making a concrete quality improvement plan, a QIP, to fix them.
Okay, hold on. The QIP, we've said it a few times. For anyone listening who isn't, living and breathing compliance terms, what actually needs to be in that quality improvement plan? What makes it a proper QIP in the eyes of the OHSC?
Good question. Because it's not just a suggestion box list. The QIP is the actionable output. Think of it like this. The assessment finds the problems. The QIP is the detailed plan to solve them. It needs specifics. What exactly gets fixed? Measurable goals. It also needs clear responsibility. Who owns this fix? And absolutely crucial, deadlines. When will it be done? Without those clear goals, assigned responsibility, and firm deadlines, it's not really the required plan. It's just ideas.
Got it. So it links the internal checkup directly to actions someone is accountable for with a timeline. Makes sense. And you made a really important point earlier we should probably stress again. These self-assessments, the results themselves.
These are internal findings.
Right.
Exactly. They absolutely cannot be used to say an establishment is compliant or non-compliant. That's not their function. The self-assessment is like the regular homework. It shows where you need to study more internally. The big exam, the certificate of compliance, that depends on a separate, much less frequent external inspection. That happens only every 4 years. So this annual self-assessment, it's really about getting ready year after year for that major inspection down the road.
Okay, so let's talk about the rhythm, the timing of this homework. The document seems very clear here. Minimum of one self-assessment per year. And it runs on a strict cycle. April 1st to March 31st. Results must be submitted to the OHSC by the end of March, every single year. Like clockwork?
Yes, that annual deadline is firm. But what's interesting strategically is the built-in flexibility. The system actually allows for up to 3 self-assessments in that same year, which suggests, that the OHSC knows that top-performing places probably aren't just doing the bare minimum once a year. They're likely monitoring things more often.
That's interesting. This option for 3 assessments, does the source give any hint if places actually do that often? I mean, if you already stretch thin, would you really triple your workload on this? Or is it just kind of there on paper?
No, the source doesn't give us usage numbers on that. But think about the implication. If you just do the 1 required assessment, okay, you're meeting the minimum standard, compliance management. But if you choose to do 3, you're signaling something different, a commitment to ongoing quality monitoring. It really forces a choice at the leadership level, doesn't it? Are we just ticking boxes, or are we actively managing risk throughout the year?
Right. And speaking of managing, this is where it gets really intense for the staff involved. Once an assessment is actually generated in the system, boom, the clock starts ticking. They have only 13 working days to get it completed. That feels incredibly fast for what sounds like a pretty thorough review.
14 working days. Yeah, that's less than 3 actual weeks. It's definitely tight. And you have to assume that pressure is intentional. It forces places to be ready all the time. You can't really afford to wait until the assessment pops up and then start scrambling to find information from months ago. It demands immediate reflection on the current state. Puts a lot of operational stress on the users, no doubt.
Okay, so the users, let's talk about who these people are, the ones facing this 14-day dash.
Right. User management is key. When the OHSC registers someone, they get an email, standard stuff, set a password, log in. But who gets registered? It's the people actually managing a service or a specific area, the responsible person for that unit, the boots on the ground.
So it's designed to be spread out,
Hmm.
not just one person trying to assess the whole hospital.
Exactly. An establishment can register as many users as it needs. The head of the surgical ward, the person running the pharmacy, the admin lead, whoever is responsible for that specific functional bit.
It forces that accountability down to the departmental level then.
Precisely. It stops it from becoming just another report for a central compliance office to fill out. Distributed input. But while the input is distributed, the final submission, that's centralized.
Ah, okay. And the rules are clear there too.
Yeah.
Yes, the document states the hospital manager or the CEO. They hold the final authority to hit submit to the OHSC. The ultimate sign-off rests right at the top. And they've thought about backups too. What if the CEO is away? 14 days isn't long.
Good point. The procedure requires a designated alternative person. This second individual gets uploaded with similar permissions to the CEO or manager, just to make sure there's always someone authorized to meet that deadline if the primary person is unavailable. No excuses for missing it.
Okay, now this next part about corporate offices is really interesting. What happens if the hospital is part of a bigger chain?
Yeah, this highlights where the system puts its focus on the integrity of the local site's assessment. People from the head office, corporate managers, regional directors, they can be registered users. But, and this is key, they get a specific status. It's read-only. They can log in, see the assessment progress, look at the data, see what the local managers are reporting. But they absolutely cannot write, edit, or complete the assessment form themselves.
Wow. That's quite a deliberate choice, isn't it? It basically stops head office from, well, maybe tweaking the results, keeps the assessment grounded in what the local manager is actually seeing and reporting.
Exactly. It protects the raw input from the person running that specific ward or department. Head office can monitor, they can react later, maybe guide the QIP process, but the initial assessment findings, they have to come directly from the responsible people on site. Keeps it honest, locally.
And with staff turnover being what it is, how does the system keep track of who these crucial users are?
Right, people change roles. So the OHSC asks for a full update on user info every year, usually around March, lining up with the assessment cycle end. But importantly, if someone leaves or a new manager starts during the year, the establishment has to tell the OHSC right away, as it happens. They need to update the system immediately. You can't have the wrong person with access, or worse, no one able to log in when that 14-day clock starts.
Okay, makes sense. So let's shift to actually doing the assessment. Users are registered, the clock's ticking.
Yeah.
How do they physically complete and upload it?
Well, there's some needed flexibility here. The ideal is electronic completion within the system, but, reality check. Maybe a specific unit doesn't have easy computer access, or maybe the manager just prefers to work through it on paper first. So the system allows them to download the assessment as a PDF, print it out, fill it in by hand. Then the registered system user just uploads that completed PDF back into the platform. So both methods work.
And what about complex areas? Like if the system just shows surgical ward, but there are actually several different surgical units?
Yes, there's specific guidance for that. If the system simplifies things, say listing just one functional area for a whole discipline like surgery, the instruction is not to just give a high-level assessment of surgery. Users are explicitly encouraged to assess the discipline manually, in detail, covering all the actual functional units under it. Then they need to combine those detailed results and upload that consolidated, more granular picture back into the system.
So even if the system looks simple, the expectation is detailed, comprehensive coverage underneath. It sounds like they really want thoroughness, even if it means extra manual work for the user.
That seems to be the driving principle, yes. Thoroughness over superficial compliance.
And if people get stuck, technically, during that high-pressure 14 days, is there help?
Yes, thankfully, there's a dedicated OHSC self-assessment support team. They can be reached by email.
Okay, let's give that out. Self-assessment support at ohsc.org.za. Good to know there's a lifeline.
And one final technical point. The standards themselves aren't frozen in time. Whenever you log in to do an assessment, whether it's the required annual one or maybe an optional second or third try, the system always provides the latest version of the compliance standards. You're always assessed against the current benchmark.
Right. So let's pull this all together. For you listening, the big takeaway here seems to be this whole self-assessment process. It's really laser focused on internal stuff. finding gaps, fixing them yourselves, planning improvements via that QIP. It's a management process, not the thing that gets you your external certificate.
Absolutely. The self-assessment is the diagnostic tool. The quality improvement plan, the QIP, that's the prescription, the commitment to act. The assessment really only counts, in a regulatory sense, if it leads directly to that implemented and monitored QIP. That's the intended outcome.
So what does this all mean? It means the system is built to be this constant loop, right?
Yeah.
At least once a year. Review yourselves, find the problems, make a plan, submit the plan. Driven by local managers, often under that pretty intense 2-week deadline.
Which brings up, I think, a fascinating final thought about strategy and resources. The system allows up to 3 assessments a year. Think about the difference between an institution just doing the mandatory one versus one that chooses to do 3. How fundamentally different must their approach to quality, their staffing, their whole culture around improvement be? Especially when that critical external inspection only rolls around every 4 years? Opting for 3 assessments a year versus 1, well, it signals a profound difference between just meeting the rules and truly embedding continuous quality improvement into the fabric of the institution. It really makes you wonder which approach yields better long-term results.